Hello, welcome to the Physical Medicine and Rehabilitation Department. Right now, I have a case here who has come with a shoulder pain. So right now, I'm going to take a brief history of this patient. And my name is Mohammed Jubish, and I'm the consultant physiotherapist for Avitis Physical Medicine and Rehabilitation Department. So what I do is I'll be talking to him in my regional language and I'll be converting that into the English so that he can understand what I'm going to take. Right now I'll be taking a brief history in which I'll have parts included will be the assessment and the subjective and objective history, including the treatment side. So basically this case has been coming to me, this is the second day for this case, and I'm treating for the shoulder pain for the second day. Our brief history has already been taken, including the range of motions and the tests, but I'll be repeating it so that you can see what kind of assessment we make here. പേര് എന്താണ്?
Cecilia.
പിന്നെ എന്താണ് നിങ്ങളുടെ പ്രശ്നം ഉണ്ടായത്?
കൈ വേദന, കൈ പൊന്തിക്കാൻ പറ്റില്ല, കൈ ഇങ്ങനെ പിന്നാലേക്ക് തിരിക്കാൻ പറ്റില്ല.
എത്ര കാലമായിട്ട് ഈ വേദന ഉണ്ട്?
6 മാസം.
എന്തെങ്കിലും എവിടെയെങ്കിലും വീണതാണോ?
ഇല്ല, ഒന്നും ചെയ്തില്ല, തനിയെ വന്നതാണ്.
ശരി. പിന്നെ പ്രഷർ ഉണ്ടോ? പ്രഷർ, ഷുഗർ
എല്ലാം നോർമലാണ്.
ഷുഗർ കുറച്ച് നോക്കിയപ്പോൾ
ഭക്ഷണം കഴിക്കാണ്ട് 100, ഭക്ഷണം കഴിച്ചിട്ട് 150.
ശരി. എന്തെങ്കിലും മെഡിക്കേഷൻസ് എഴുതാക്കുന്നുണ്ടോ?
മറ്റേ ബേപ്പിയുടെ ഗുളിക മാത്രം കഴിക്കുന്നുണ്ട്.
ബേപ്പിയുടെ മാത്രം കഴിക്കുന്നുണ്ടല്ലോ. ഈ വേദന വന്നിട്ട് എത്രയായി?
6 മാസമായി. ഒരു 2 മാസമായിട്ട് കൂടുതലായി.
ഏത് കൈയിലാണ് വേദന?
അടുത്ത കൈ.
ഇതിങ്ങനെ വേദന വരുമ്പോ പിന്നെ കഴുത്തിന്റെ അവിടെ നിന്ന് കയ്യിൽ താഴെ വരെ വേദന?
അവിടെ ഒന്നുമല്ല, ഇല്ല, കൈയിൻ്റെ അവിടെ മാത്രം.
എന്തെങ്കിലും കുത്തുന്ന പോലെ ഉണ്ടോ?
കുത്തുന്ന പോലല്ല, വേദന.
ശരി. പിന്നെ ഉറക്കം എങ്ങനെയുണ്ട്? ബുദ്ധിമുട്ടുണ്ടോ ഉറങ്ങാൻ?
ഉറങ്ങത്തിന് ബുദ്ധിമുട്ടില്ല, പക്ഷെ തെരഞ്ഞു കിടക്കുമ്പോൾ പെട്ടെന്ന് വേദന വരും.
പ്രത്യേക സൈഡിലേക്ക് കിടക്കും. ഇത് ഏത് സമയത്ത് വേദന കൂടാതെ?
24 മണിക്കൂർ വേദനയാണ്. ഇവിടെ ഇത് ചെയ്ത ശേഷം നമുക്ക്
കമ്മിയായി. പക്ഷെ രാത്രിയോ രാവിലെ അങ്ങനെയൊന്നും ഇല്ല. വെയിറ്റ് എന്തെങ്കിലും എടുത്ത് പൊക്കുമ്പോൾ
തൊടാൻ പറ്റില്ല. വേദന വേദനയല്ല, നമ്മളിങ്ങനെ എടുത്തിരുമ്പോ ഇവിടെ അങ്ങനെ പിടിക്കുക. ഒരു ലിമിറ്റ് കഴിഞ്ഞാൽ കൈ പൊക്കാനൊന്നും പറ്റില്ല. ഇപ്പൊ അതൊക്കെ പിടുത്തമൊക്കെ പോയി.
പിന്നെ ഷർട്ട് ഇടാൻ ബുദ്ധിമുട്ടുണ്ടോ?
ഷർട്ട് ഇടാൻ കുറച്ച് ബുദ്ധിമുട്ടായിരുന്നു, അത്രയില്ല. കൊണ്ടുകൊടുക്കാനും ഷർട്ട് ഇടാനും ഇതായിരുന്നു. തലേ കൊടുക്കാൻ ഈ കൈയോടെ പറ്റില്ല, ഈ കൈയോടെ അങ്ങനെ ഇത്ര പൊങ്ങുള്ളൂ. ഇപ്പോഴും അത്രേ ആയിട്ടുള്ളൂ.
പിന്നെ കുളിക്കാനും
ഈ കൈയോടെ തന്നെ, ഈ കൈയോട് തുറത്താൻ പറ്റില്ല.
ജോലി എന്തായിരുന്നു പറഞ്ഞത്?
ബിസിനസ്.
അപ്പൊ ആ ബിസിനസ്സിൽ നിങ്ങൾക്ക് വലിയ വെയിറ്റ് ഒക്കെ എടുത്ത് പൊക്കേണ്ടി വരും. കഴുത്തിന്റെ വേദന
വേദനയില്ല.
ഡോക്ടർമാരെ മുമ്പ് കണ്ടിട്ടുണ്ടോ?
അത്താണിയില് ഡോക്ടർ സത്യനാരായണൻ 10 ദിവസം മരുന്ന് തന്നു. പിന്നെ വേദന കൂടുതലായി. അപ്പൊ നേരെ ദയ്യിൽ പോയി. ദയ്യ എന്ന് പറഞ്ഞിട്ട് സാറിന്റെ അടുത്ത് വന്നു.
ബിപിക്കുള്ള മരുന്ന് മാത്രമേ കഴിക്കുന്നുള്ളൂ. Right now, I've taken a brief history of subjective history of this patient. This patient, his name is Shashidharan K, and he is having a continuous shoulder pain, and he was having it for past 6 months. for past 6 months he was having this pain, and last 2 months this pain has aggravated. Currently this patient is under medication for blood pressure, and he has a borderline type 2 diabetes mellitus of postprandial of 180. He is having a measure of sugar, hypertensive, and he is having this pain, especially not in the night and not in the morning, but all through the day. Whether regardless of AM or PM, he is having it all through the day. He has trouble sleeping on the involved side, especially it's on the left side, and it is not. ഇത് നിങ്ങളുടെ ഈ കൈ നിങ്ങളുടെ ഏത് കൈയാണ് ഉപയോഗിക്കുക? ഏത് കൈയാണ് കൂടുതൽ ഉപയോഗിക്കുക? ഇടതോ വലതോ? Well, no, it is not his dominant hand. That we have to see. It is not his dominant hand, and he is taking medicines for blood pressure, and past. Eppran doctor kandadu last month he saw a doctor, an orthopedician, and the orthopedician gave him a medicine, few medicines, anti-inflammatory and analgesics, which he says only had temporary relief, and afterwards the pain actually aggravated. So, and he is a businessman, and he at his job he has to take some of the heavy machines. He has to do some heavy machines, and he has to take heavy objects. So that also has aggravated this condition. That is a brief history of this patient. Now we can see some objective. What we can see is we can ask the patient to remove the shirt, and we can see an objective examination. So for that, I'll ask the patient to undress himself, and we'll see what all things we can see as we can go for on object on palpation and on examination. On the shirt it's not So basically, if you take the shoulder complex, we have to see from all the sides. We have to see from the anterior, posterior, and the sidewise. Right now, this scapula has been supported. So what I suggest is, I'll ask him to sit a bit in front, so that you can see what is the shape of the shoulder. Right. Now it's classical that you can see a rounded shoulder here. If you look at from the sides, right. So on the posterior side, when you can see clearly there is no sign of any muscle wasting or any sort of thing. That is clear. Right. But you can see there is a bit of maybe because of the pain, he is protruding a little bit of the shoulder complex. He is taking the scapula to the left side, and from the anterior side, if you can see, again there is not much of evidence of any muscle atrophy or any kind of thing. So there is no evidence of muscle wasting. You can see only a protruded or a rounded shoulder, right? Maybe he is towards this area because he is a bit upside, because he is having a muscle guarding response. That is why he is protecting this area. Right? It's kind of apprehensive. So next we will go for winging. If you see, you have to see for the cervical and the scapula side also. You have to see whether there is any winging of the scapula. There is no winging of the scapula. You can actually see the shoulder complex is entirely rotated because of the apprehension towards the pain. So he's lifting it and he's dropping it. So it is thoroughly because of the pain, and you can see this. There is a muscle tightness in this area, especially the trapezius area, because again he is doing a shoulder stretching and keeping it like that, so that there is no pain. Right. Okay. Now we can see on examination we have to see whether we have to see all the joints, especially the acromioclavicular joint and the sternoclavicular joint and the
the spine also. So the spine of the scapula. See. So why the spine of the scapula? Everything is seen as we have to see this for the symmetry, right? So symmetry both, and especially when you compare the shoulder, you have to compare it for both sides, right? The deltoid wise and the spine of the scapula, whether it is in alignment. You can see this is a bit up and this is a bit down. If you mark it clearly, and you can see the muscles also. The muscles is a bit up here, uppish, because there is a bit of tightness towards this muscle. Clear? So the asymmetry wise, you can see the deltoid. You have to palpate the deltoid. You have to palpate the joints, acromioclavicular joint, the spine of the scapula. See, the simple thing to palpate the acromioclavicular joint is when you palpate the spine of the scapula, you end up in this acromioclavicular joint, and just 1 inch below it, you can clearly palpate the thoracoid. Right. So these two palpatory landmarks has to be always palpated so that you can easily palpate the deltoid and the other muscles. Right. So this is the field. On examination, we have to see all these things, especially these important structures. Next, for the range of motion, I already had done the range of motion for this patient. I just ask the patient to lift his hand and for all the movements, including flexion, extension, abduction, and the rotations. So we can see. I'll ask the patient to do it. You can see the clear classical sign of this, the shoulder pain. See, the patient is able to do only this much of flexion. So roughly, I have seen the patient can only do 120 degree of active flexion, and in this, on the other hand, he can do 180 degrees of active flexion. Right. At the same time, an extension of you can see around 45. You can see clearly, but see, that's why you have corrected 45. Whereas in this hand, you can see a complete extension. Right. Then on abduction, there is 90 degree abduction. Is clear, but again there is a bit of problem with scapula. So I'm correcting the scapula and asking to do an abduction, and beyond that he cannot do it because there is a limited, it's restricted, and pain and the restriction is there. Right. Then if you go for the classical internal and external rotation, right, so see at the bending itself he has a little bit of pain. So I ask the patient to flex, see, so the whole body is being turned. So you can see there is a minimal and very restricted range of motions in internal and external rotation. So because the patient is having severe pain and apprehension, I didn't want to make him do a range of motion today itself because we had done it yesterday. So on calculative side, we have a shoulder flexion of 120 left active and 180 to the right, 45 to the left, 60 to the right, 100 to the left, 180 to the right, and 40 to the and the internal rotation is 40 and 70 to the right, 40 to the left and 70 to the right, and 30 to the left and 70 to the right. And you can see there is an increase in passive. If you see, there is a mild increase that I can say it's only up to plus 5 or maximum plus 8, 5 to 8 degrees of improvement in passive range of motions. Right. So these are the things which we see on objective examination, especially the range of motion, and the muscle power is almost, you can see. See, it is 4, and you can see thoracic. ഉള്ളിലേക്ക് കൈ ഉള്ളിലേക്ക് അല്ല അങ്ങനെയല്ല കൈ ഇങ്ങനെ വെച്ചിട്ട് ഉള്ളിലേക്ക് മേലേക്ക് ഓക്കെ So he has a muscle power of 4, almost 4 for all the movements except external rotation, because external rotation it is a bit painful and it is restricted. So apart from that, his muscle power is all good. So next thing what I'm going to see is it is for the test, right? Because we have to rule out certain things here. Now with the shoulder is a bit tricky here, because the differential diagnosis, you have plenty of differential diagnosis. So the one thing you have to look after is, the first and foremost thing you have to see is the first thing is the cervical. The cervical, then only you run into the shoulder complex, because otherwise because the patient complaints can vary, right? And we have certain lot of conditions like fibromyalgia, even cervicobrachialgia. All these things can, all the dermatomas and everything can spread, and the patient can complain pain over deltoid and the radiating pains. So what you need to do is very simple test, and not so complicated. We can rule out with each single test, so each one by one test. So first thing, cervical, you have to rule out with a special test. So what you need to do is either you can go for a compression test or a distraction test, right? As you can go for a compression, or you can go for a distraction or a compression and ask whether the pain is radiating or not, right? Or else you can do the other easy thing is you can go for a Sperling's maneuver. Sperling's maneuver is hyperextension of the neck, that is cholo, and right side, and you give a compression to the head. So what happens is, if there is on the involved side, the patient will have severe pain and paresthesia on the involved side. So by this you can rule out whether it is a cervical pathology or not. Right. Now, when it comes to the shoulder, right? Now shoulder, we have to go for a conclusion here. So we have to test everything, each and every muscle. So first and foremost thing we can take as a subacromial joint, right? Subacromial joint, you can easily point out is a Hawkins-Kennedy test, right? So Hawkins-Kennedy test, you can ask the patient to flex and flex the elbow, right, to 90 degrees, both into 90 degrees, and you can ask the patient to go for a So this is clearly negative, right? Subacromial is Hawkins is clearly negative, clear. And next is acromioclavicular joint, right? So acromioclavicular joint, you can go for a scarf test. You can ask the patient to do an adduction. So ingane kondu kai alla kai idu nurthi kodu inni ulli kondu ulli idu ulli, and ask the patient to do an adduction. Resisted adduction will cause a pain in the acromioclavicular joint, in which pain is there is no pain for this patient, right? So it's called a scarf test. Next, you have to see the rotator cuff, right? Rotator cuff, you have to see rotator cuff integrity test, right? So easy test is you can go for, first and foremost thing, you can go for a MT-CAN test, right? MT-CAN test, you can easily ask the patient to do, and one thing is you can ask the patient. So you can ask the patient to do an MT-CAN test. You ask the patient to go for a flexion and the resist at the wrist level. Right. So in this, you can go for a, if the patient has a pain, then there is a supraspinatus involvement. Supraspinatus impingement is there. Now the patient doesn't have any pain. Right. So that is MT-CAN test. Now next is infraspinatus. So that is, for that you can go for a Pantis test. Pantis test is very easy. So now you can see, you keep the patient 90 degree shoulder flexion and elbow flexion 90 degree. Ask the patient to go for a external rotation. Resist the external rotation. Pinnala kai pinnala kondu right. No. So the infraspinatus is clear. So like this, you can rule out the integrity test, right? Supraspinatus and infraspinatus. Now next thing is you have to go for, always you have to go for, because since it's a shoulder and you can see the biceps is a major muscle which is connected to the shoulder, so we have to check for the bicipital tendinitis, if there is any bicipital tendinitis or the biceps rupture is there, so we can go for a speed test, right? Kai ingane vikkum, ini mele vikkum, ഇല്ല മടക്കാണ്ട് മേലെ മടക്കാണ്ട് ഇങ്ങനെ മേലെ പൊന്നിച്ചോ വേറെ ഒന്നുമില്ലല്ലോ So this is the speed test, right? You can clearly rule out the speed test. So then we have to go for the deltoid, right? So deltoid, it's very pretty much easier test because deltoid up to 90 degree, you ask the patient to lift and resist the muscle strength, resist the muscle beyond 90 degrees, right? So right, so in this he also doesn't have any pain, right? So deltoid also is clear. Right, now the last thing which you want to do is a serratus anterior test. Now this two ways you can do it. Either you can ask the patient to push through a wall or else എന്നിട്ട് കൈ ഈ ഇടുപ്പിൽ വെച്ചോളൂ എന്നിട്ട് ഈ മുട്ട ഇങ്ങനല്ലേ ഇങ്ങനെ കൊണ്ടുവരണം കേട്ടോ ഇങ്ങനെ അങ്ങനെ കൊണ്ടുവരണം അപ്പൊ ഞാൻ ഇവിടെ അമർത്തും ഓക്കെ so this way you can see whether there is a winging of scapula, right? So what you are doing is you are resisting the scapular range of motion. So if there is any winging of scapula, it will be clearly evident from this resistance. You can ask the patient, either we can do like this or ask the patient to do it against the wall, right? So that is a brief special test what we have done to this patient, and we can see the special test is all clear. Now, so we have ruled out almost all the possibilities, but we have to rule out the laxity and the stability test also, because it's very, very important, because the ligament plays a major role. So in order to rule out the laxity, we can do a Drawers test, and in order to rule out the stability, we can do an apprehension test. Right. So what we can do is for കുറച്ച് മുമ്പിലേക്ക് see, there is a big difference between laxity and the stability, because stability is totally different from laxity. So we are checking for the laxity, we are checking for the ligaments lax, how much it is lax, right? It can go, it can stretch, it can go. Whereas the stability is totally different, because stability is how much it is kept under tension and how much we can go for the pull and the push. So for the laxity purpose, you can palpate, right? You can palpate the behind, and you can palpate from the acromial clavicle joint, and what you can see is a bit 1 inch down. You can go for the head, and what you need to do is you can put a hand over here so they can really know the translation field, and you can go for a Drawers test. You can use either your thumb or you can use the complete whole hand, lower hand, and you can go for a anterior translation, and you can see whether there is a clunk, or you can see a clunk means if there is a labral tear, you can see it easily translates and it will go beyond the limits, right? Or if it is about stability, again we have to go for a 90-90 position, right? And what you need to do is the patient has an apprehension because of the pain and range of motion, but you should not get confused, because what you need to do is you need to pull it at the wrist level, at the same time you need to give a translation at the behind. So why? Because the patient will show the apprehension, right? So that suggests there is a stability issues, but the stability issue doesn't stop with that, because you have to go beyond this test. If this test is positive, then we have to go for a Jobs test. So there is only a pain, because the pain is purely due to the external rotators involved and the stiffness. So right now we can say the stability is not an issue here, right? So these are some of the special tests we rule out for the shoulder examination. Now we have to see, so we have seen all the possibilities, but we have to conclude this. So the last but not the least is because of the history, the patient has a history of diabetes mellitus and has a borderline diabetes mellitus, which in turn can go for a capsulitis, right? Because there is always a science, and in this area and the south of India, we have a lot of diabetes mellitus shoulder. That means we call it as a diabetic shoulder these days, because a lot of diabetes people, they come with this shoulder pain, and we call it as a frozen shoulder, and they usually come in the second stage and the frozen stage, and this is a typical, classical example of the frozen stage shoulder. Some of the patients rarely come with the thawing stage, so that thawing stage is very difficult to treat. So usually at this stage, what happens is if the patient is not getting comfort with this kind of thing, then we'll ask the orthopedics to go for a manipulation anesthesia, and then we'll go for a rehabilitation. But now this patient has got almost a 120 degrees, so he needs functional activities only, he doesn't need anything else. So what we suggest is we go for a capsulitis, a capsular stretch. Right. Now the only difference between the other possibilities involved, like the special test and this aggressive capsulitis, is the capsular restriction in patterns. So if you see the capsular restriction in patterns, you can see restricted external rotation, clearly seen there is an external rotation, right? Restricted external rotation, then it is going for an abduction, is restricted, right? Then the internal rotation. So this capsular restriction is there, which in turn shows that the patient has a adhesive capsulitis, and you can clearly see that when you give a stretch, it's been relieved. The posterior capsular stretch, it has been relieved, right? So this is the major concern, especially. So that is how we conclude, right, whether this is purely based on adhesive capsulitis, because of the history and because of the capsular restriction. Now if you can see clearly the capsular restriction, you can palpate the structures around it, and you can go for a external rotation. You can see there is a capsular restriction, because the end fields are like that. That's why I say the end fields, you have to always palpate the structures around it, because the end field, the bony end field and the spongy end field, all has to be done, and you can see there is a clear capsular restrictions, right? So external rotation, then goes for abduction, then is going for a internal rotation. So this is where we come into a conclusion that is this mostly it might be an adhesive capsulitis, and no diagnosis is a diagnosis unless we have a radiographic appearance. So this patient, we already have seen the radiographic appearance, and he has taken X-ray has not gone for any any radiographic appearance or evidence. But it's typically these kind of adhesive capsulitis, we will not see any kind of major things in the X-rays, but in scans you can see a soft tissue involvement there, a bit of adhesions there. So the only thing which we can do is we can go for clinical symptoms and the clinical symptoms, and according to clinical symptoms we can go for a treatment. The treatment part is very important. Treatment
അല്ല ഇന്നിപ്പോ വെക്കാൻ നേരമില്ലേ? അല്ല
അത് 10 മിനിറ്റിന്റെ ട്രീറ്റ്മെന്റ് മാത്രം വെച്ചിട്ട് പോകാം. ഒരു എത്ര സമയം? Okay. Right now we'll come into the treatment part, and the treatment part, what we are going to do is we are going to use a tool called as PADI, which is Shoulder Pain and Disability Index. Right. And according to this PADI only, we are going to progress the treatment. Right. So what we are going to do is we'll be scoring this PADIs. Right. So we have already taken the scores, in which he has a total pain score of 54% and the total disability score of 57%. and the total study score is 5.7, which is a bit worse here. Right. So, and this is the first day of review. This will be reviewed after 7 to 10 days when he is undergone all the physio treatment. Right. So, as per the physio treatment, we are going according to the NICE guidelines and the evidence-based practice. NICE guidelines and the CSP guidelines suggest that for this case, especially for the adhesive capsulators 2, phase 2, we will be giving a grade 3 mobilization which is comfortable, and if it is not grade 3 then we will Maitland's mobilization. If it is not grade 3 then we will jump into the grade 2, right? And subsequently what we suggest is I will basically go for a grade 2 because the patient is having a restricted range of motion and a pain, so I suggest we'll go for a grade 2 and jump into grade 3, or else grade 2 and go for a grade 1, right? Plus we will go for stretching, capsular stretching, and we'll go for, at the end, we can go for healing purpose, we'll go for a pulsed ultrasound therapy, right? Phonophoresis can be given. Apart from that, the patient will be taught all the Codman Spindler exercises and the range of motion activities up to the restricted range of levels. Kadakku. ഈ കഴിഞ്ഞല്ല അപ്പൊ കാരണം അല്ല ആദ്യം ഈ കഴിഞ്ഞല്ല അല്ല ഈ കഴിഞ്ഞല്ല. Make sure that the patient is in the right position and he is comfortable, right? And the couch is adjusted so that you are in the right position and right stance to give the mobilizations. So I always start with the mobilizations.
എൻ്റെ പേരിലാണ്. പക്ഷെ ഒരു കാര്യം ചെയ്യൂ, ടോക്കൺ എടുത്തിട്ടൊന്ന് വെയിറ്റ് ചെയ്യൂ. ഒരു 10 മിനിറ്റ് കഴിഞ്ഞ് ഞാൻ വിളിക്കാം, എന്നിട്ട് ഇങ്ങോട്ട് പേഷ്യൻറ്റിനെ വിട്ടാൽ മതി. ആ ശരി.
Now we can see the patient and the positioning of the patient, and we are going for a anterior. So we can go for anterior grade mobilization, and we can ask the patient to flex and give a traction here, right? And give a traction and go for a mobilization. So give 20 seconds to 30 seconds repetition, and followed by at least 2 to 3 minutes of the. Then again follow the patient with the flexion, traction. Passively, can give a mild traction and go for a flexion. See, we can use a lot of techniques here, but Maitland will be much more effective.